I am John Arch. I'm the Executive Vice President of Healthcare at Boys Town and Director of Boys Town National Research Hospital in Omaha, Nebraska. I'm honored to represent Boys Town. Founded in 1917, we serve now over 72,000 kids each year across the United States, 9 different states with sites. We have a mission that is very bold. We want to change the way America cares for kids, families, and communities. And so that's what brings me here today to talk about the use of psychotropic meds, in particular one service that I'll mention here in just a second. Boys Town is divided into 2 divisions. There's a youth care division and a health care division. The youth care division is probably the better known division in that that's the Mickey Rooney, Spencer Tracy, the movie Boys Town, that residential care. While residential care was where Boys Town started, most of their care now is in-home services, trying to keep families intact, trying to keep kids in the home, and those are, again, across 9 states. Healthcare division that I'm responsible for has the medical services, medically directed services, as well as medical research. I mentioned communication disorders in children, as well as the behavioral health research. Our division, the healthcare division, serves 45,000 children annually, and including the most troubled kids that Boys Town care for in our residential treatment center. Since opening this center in 1996, we have accepted kids from 38 different states for treatment there. And this treatment center is located in Omaha, Nebraska. So our treatment center provides a secure environment that's designed to offer medically directed care for the most seriously troubled youth. So if you can imagine this continuum of care, inpatient care would be the most acute care, and that's usually a 3 to 5 day length of stay. The residential treatment center is a step down from that care, and there we treat children from ages 5 to 18 and approximate length of stay of about 120 days. So these children do not require that acute inpatient care. Their crisis is stabilized, where perhaps they were a danger to themselves or others at that time, and then they maybe step down to our care in the residential treatment. But they include school failures, multiple placements, perhaps a history of self-injury, the truly serious. Most kids have had some contact with the law by the time they reach the residential treatment center. They've not been successful at lower levels of care. They've experienced multiple placements within the mental health system. So they are admitted to the residential treatment center. The child psychiatrist is the medical director and the head of the treatment team. The treatment then begins with the assessment of the child, and very, very specific. We call it a biopsychosocial treatment model that includes both that medical, the psychological, as well as the social aspects of that child, the behavioral treatment. The model of care at Boys Town is very behavior focused. So when the child is admitted to the residential treatment center, certain behaviors are identified that child needs to work on. During the day, that behavior is taught to. All the while there is a medical management that is going on regarding the use of meds. When we see kids enter our program, we see kids on multiple psychotropic meds generally, and we've had kids up to 8 different psychotropic meds admitted to the program. This is a result of them seeing different physicians throughout their life, perhaps a family practice, pediatrician, maybe a child psychiatrist, and all attempting to help the family get some self-control and some control with the child's behavior. And so when they come to us, it's because that has not been successful. Approximately 79% of the children that are admitted to our treatment center are being prescribed at that time multiple psychotropic meds. And like everyone has testified, we're also very concerned about this lack of scientific evidence as to exactly what these antipsychotics can do, both developmentally as well as educationally. When these kids come to our program, they're generally 2 years behind in the educational process and need to catch up. So I have an example. I'll call the child David. He came to us in his early teens. He weighed about 300 pounds, and he was really struggling. He had some extreme temper issues. He was referred to us by a judge to seek some care. We began to reduce the number of psychotropic meds as well as doses, and successfully over a period of time he was tapered off several of those meds as well as reducing the doses, and he was able to move down to one of Boys Town's residential homes. He actually graduated from the high school and went on to an engineering career at the university. So that combination of reducing those psychotropic meds and putting in self-control, those behavior interventions, has worked within our treatment model. So we've seen a significant, we had a recent study that was conducted at our treatment center, and utilizing this medication management program within that structure of the strong behavioral, we demonstrated a 33% reduction in the number of youth on any psychotropic med, a 38% reduction in the average number of meds being prescribed at the time of discharge. So we moved from about 75% of our kids on meds in the residential treatment center to 50% upon discharge, and then we reduced from about 3.3 average medications per child to about 2.1. So in both dose as well as removing completely from psychotropic meds by putting the behavioral model and other interventions into place and teaching to that behavior, we saw that. And actually we saw a 63% reduction in aggressive behavior at the same time we were moving these kids off of these psychotropic meds. So it obviously was successful in doing that. But our mission is to change the way America cares for kids, so we're pushing hard into behavioral health research, as we've done in our communication disorders research. And in 2012, we hosted an NIMH-sponsored conference specific to psychotropic meds in kids, and gathered experts around the United States to come to Omaha to discuss that, and created some task force, and those task forces going forward are going to be taking a look at the forces that drive the current high medication rates, establishing processes for taking children off the medications, and defining effective management of medication use within the context of other treatments. So that work is ongoing after that NIMH-sponsored conference. But we needed to do more, so we launched a Neurobehavioral Research Center in Omaha. We want to take a look at not only the psychotropic meds, but also alternatives. What we see is not enough evidence of the biological markers. So using fMRI, we want to use that as a primary research modality. Take a look at kids. One of the studies we have is as they come in on multiple psychotropic meds, having that fMRI done at that time, and as we move the kids off psychotropic meds, continue to examine are we seeing a normalization of brain activity as we remove these kids and we put other interventions in place, behavioral interventions. But we want to take a look at exercise, see what that does. We want to take a look at some of the more alternatives, such as computer games specifically designed to treat depression, and see if some of that can be used. Whatever we can do in an attempt to reduce and only use medications when appropriate and when necessary, and implement other alternatives. So thank you very much for allowing me to speak today, and I would encourage this committee and the senators to consider very seriously the ongoing funding for research that's needed, as well as those alternatives are developed in intervention strategies, that those alternatives are available in communities, because that's what's driving a lot of this. Some of the physicians don't have alternatives in those communities to refer to, especially as you get into the rural areas. And so they are left with desperate parents that need psychotropic meds, something to control the behavior of their child. So please continue that funding. Thank you very much.